Okay, welcome back to the second part of our EKG interpretation lecture. We're going to continue on where we left off on heart blocks. We're talking about atrioventricular heart blocks and beyond that as well. We have more content that we will go back to and address in a little bit more detail than we previously mentioned. And first we have the first degree atrioventricular heart block. Okay, this is a 6-second strip, as we can see by the markings at the top of the EKG paper. So it is a 6-second strip, and at first glance, it looks pretty regular, and it looks like a normal sinus rhythm, or 1, 2, 3, 4, 5, perhaps bradycardia, but it looks pretty much normal. Likely between this and this, we have a normal rate of around 60. So at just first glance, that's what you might think. We have the P, QRS, T, P, QRS, T. And so it looks really quite normal. And there appears to be a P wave before every QRS. So it looks like maybe this is a normal sinus rhythm or possibly a bradycardia, sinus bradycardia. But that is not what it is at all, because if we go on and measure the intervals, we will discover something else about this particular EKG tracing. Now the QRS complex, it looks narrow, so that's not a concern. It's less than 0.12 seconds. That looks good, less than 3 small boxes between here. The real concern here with the first degree AV block is this interval here, the PR interval. Remember, the PR interval should not be prolonged. It should not be greater than 0.2 seconds, which is essentially one large box. And you can clearly see that it is beyond prolonged, this time interval, beyond 0.2 seconds. So the PR interval here is prolonged, and this is the exact scenario that occurs when a patient has a first degree AV heart block. Some might say that it is not a true heart block, but it is most definitely a delay at the AV node. Okay, that prolonged PR interval indicates that there is a delay at the AV node. Each impulse is eventually conducted, so that's why we might argue that is not a true heart block, because there is not a impulse that does not get conducted. Every impulse gets conducted, although it is delayed, and results in a ventricular contraction. Okay, so they do get through, but it is a heart block, and we need to monitor for that patient. And so the treatment is going to be just that, to continue to monitor this patient, because it certainly could progress to a second or third degree heart block, which we'll discuss. We have two different types of second degree atrioventricular heart blocks. Okay, the first one type we'll talk about is called Mobitz type 1. We see with the second degree heart blocks, with Mobitz type 1, and let me also tell you that we have another name for Mobitz type 1, and that is the one that we use most around the hospital floors and units, and that is Wenckebach. It's spelled W-E-N-C-K-E-B-A-C-H. Mobitz type 1, also called Wenckebach, is a type of second degree heart block. We love to discover this. Nurses get very excited when they've got a patient who's got Wenckebach, because what they get to show you is that the PR intervals become increasingly longer in this rhythm strip, until finally one of the P waves is blocked from being conducted, and that impulse is not completely conducted. Okay, so that the P is blocked from occurring. So let's look at this. It appears to be, there's a P wave, QRST, P, QRST, P, QRST. Then there's a P, but the impulse is not conducted. It doesn't make it through. There's a block somewhere preventing the P wave contracts, but there is no contraction of a ventricle following it. Okay, so that beat has been dropped. Notice you measure the PR interval. Here it's clearly less than 1 big box. The PR interval here is greater than 1 big block, so there's already prolonged. But look at the next one. Look at the PR interval here. It is even longer. So we say it gets long, longer, drop. The PR interval gets increasingly longer until one of the P's is blocked right here. Okay. So if we would count on this strip the number of P waves, 1, 2, 3, 4, 5, 6, 7, 8, and then also count the number of QRSs, 1, 2, 3, 4, 5, 6. Okay, so clearly there are more P waves than QRSs. There is not a 1-to-1 ratio between atrial contractions and ventricular contractions. So that means that the impulse is not getting through. It is blocked. It's the P waves contracting, but it is not followed by a ventricular contraction. Okay, and therefore the rhythm looks irregular. Okay, so I think we did a nice justice to that type of second-degree AV block. Here's the second type, Mobitz type 2. It's a second-degree heart block. With this particular type of heart block, we see that the PR interval is constant. So that's the word we would use to describe the PR interval. It is a constant interval. If we measured them, they would all be the same. We do not see that increasingly longer at all. The R to R is usually regular, but that can vary. It can be irregular. One thing that we will definitely see in a second-degree heart block is that there are more P waves than there are ventricular contractions. Okay, so look at this one in particular. 1, 2, 3, 4, 5, 6, 7, 8. 8 P waves. Normally, we have 1 atrial contraction for every ventricular contraction, and here we only have 3 ventricular contractions. Is there a problem conducting that impulse? Absolutely. There is a block. Okay, let's see if there's anything we didn't mention down there. Okay, so you see a P wave did not result in a ventricular contraction. This one did. Okay. All the PR intervals, if you measure them, the ones that have a Q, if you measure those, they're all the same. They happen to be prolonged, but they're all the same. No increasing it in length. Okay. A third-degree AV heart block is also referred to as a complete heart block. Initially, as a new student, somebody who's learning how to read EKGs, it can be very difficult to distinguish between a Mobitz type 2 second-degree heart block and a third-degree heart block. So I'm not going to ask you to do that because it can be very confusing. However, you do need to know how to treat these more advanced heart blocks. Okay, we'll talk about that. So let's look at this third-degree heart block. I like to give a little story because let's look at this, the way that these P waves and ventricular contractions go here. P, QRS, looks like there's a P, P, QRS, P, P, QRS, P, P. So what's going on here is that the atria and the ventricles are completely disassociated. Okay, so I like to give that story of a divorced couple living in the same house. Okay, for whatever reasons, they've had to stay in the same house, but they're legally divorced, and they're each doing their own thing. Okay, I'll say that one person in the couple is coming and going as they want. They're just living their life like they always have. That's what you can think about as the P wave. The P wave is just firing impulses, just doing its own thing, and the ventricles, the ventricular contractions, are doing their own thing. They're not listening to this one, and the impulse is not coming through and telling it to contract. It's contracting whenever it wants to. Now, same here. The ventricle contracted whenever it wanted to. It had nothing to do with the impulse that came from this one because they aren't speaking to each other. It just happened to land near this P wave on the tracing. Okay, so they're completely independent. They're each doing their own thing, but they're still residing in the same house. They are not communicating with each other. Okay. Let's see what else we have to say about this one. So the atrial and ventricular activities are unrelated. And the reason for this is that there is a complete blocking of those atrial impulses to the ventricle. It doesn't get to the ventricle. So these ventricular contractions occurred because of some other ectopic foci area of the heart that decided to initiate a ventricular contraction because the impulses from the atria and the SA node are not getting through. Okay? Well, this is a problem, as you might imagine, what this type of heart block is going to do to your cardiac output. Okay? It's going to severely impact cardiac output, and so for this reason, the patient would require a permanent pacemaker to be placed. Okay? The pacemaker will ensure that we have synchronous activity in the heart and contractions that can generate a decent cardiac output. So you need an emergent permanent pacemaker placed. Okay, we cannot wait around. This has gone on. This is not looking good when there's a third-degree heart block, and it's not looking good in the same situation. We could talk about the second-degree heart block, especially Mobitz type 2. That too may need a pacemaker. Now, when I say a third degree, the definitive treatment is a permanent pacemaker. That is true. But could they, because you haven't learned about pacemakers yet until the next lecture, but could they schedule a permanent pacemaker in the cath lab tomorrow? Well, yes, they could. It's still emergent. They still need to do it as soon as possible. But in the meantime, they can use a temporary pacemaker because we have temporary pacemakers, and that will suffice until the patient can get down to the cath lab, for example, and have that permanent pacemaker placed. Okay, so don't get tripped up on test questions that might say, oh, a patient has a third-degree heart block, what should the treatment be? And one says a permanent, a temporary pacemaker. Yeah, that's a good answer too. Temporarily, we can get a temporary pacemaker would be perfect because that means right away the patient is going to have pacing capabilities that will improve the function of their heart. But they eventually must get a permanent pacemaker. Okay? A temporary pacemaker means they're in the hospital and waiting. Okay? They don't go home with a temporary pacemaker, but it's something that we have available to us in the hospital. All right, so let's talk about nursing diagnoses related to dysrhythmias. Remember the electrical conduction system of the heart. We're not talking about perfusion in the sense of a coronary artery, but we still have decreases in cardiac output when patients have different arrhythmias, or we can call them dysrhythmias. Either one is appropriate, either term. I think we've made it pretty clear as we went through this presentation that no matter the dysrhythmia, that the patient's going to experience decreases in cardiac output as a result of changes in the heart rate, because remember, cardiac output equals stroke volume times heart rate. So when you change the heart rate, that's an arrhythmia. That is an example as well of how a heart rate can impact cardiac output. The rhythm as well, because when the rhythm is really off, then we don't have a synchronous pumping action to move the blood forward. And this can impact cardiac output as well. So when a person has a dysrhythmia or an electrical conduction problem in the heart, it can result ultimately in a dysfunction in the mechanical functioning of the heart. Okay, so the heart simply does not pump effectively, and that influences the cardiac output. What about nursing interventions for our patients with cardiac arrhythmias? Nursing interventions involve assessments, assessing the patient for the underlying cause of the arrhythmia. What is contributing to this arrhythmia? Sometimes, especially when you think of sinus bradycardias and sinus tachycardias, we simply have to correct the underlying cause, and that will eliminate the arrhythmia. We also talked about that. A good example was magnesium. If it's a low hypomagnesemia in for example, we said alcoholic patient, and he develops torsades, we can correct that underlying tachycardia, ventricular tachycardia, by simply giving them magnesium supplements. Okay, so look and assess the patient for underlying causes so that we can correct that cause and get rid of that arrhythmia. Also, we will certainly assess our patient for signs and symptoms of impending failure. There's a lot included in that. Certainly, we have to assess our patients for signs and symptoms of impending heart failure as a result of these arrhythmias. This includes a thorough physical assessment, focused on perfusion, and review of lab values, especially with heart failure. If we are aware that they could develop an acute heart failure, which labs are you going to be interested in reviewing? Okay, so there's certainly that to consider, especially things like a BNP. For physical assessment, you must be listening, auscultating the bases of the lungs for crackles, and also observing for shortness of breath. Respiratory rate is elevated, oxygen saturation is dropping. So we have to look always for complications as a result of these arrhythmias, and heart failure certainly can be one of them. We need to look at hemodynamic parameters, especially our blood pressures, okay? Because remember, when cardiac output falls, blood pressure falls as well. And that means that vital organs, we take it to the next step, That means vital organs do not get perfused when the blood pressure gets too low as a result of decreased cardiac output. Especially we think about the kidneys. And so we would want to monitor or review lab values such as the BUN and creatinine, because certainly if the kidney is not being perfused adequately because we have a weakened heart and decreased cardiac output, the BUN and creatinine will rise or become elevated. Okay, also we already talked about correcting underlying causes. We went over this before. But I do want to talk about the Valsalva maneuver real quickly. Okay, as we're learning, abnormal heart rhythms occur for several reasons. Vagal stimulation, like what occurs with the Valsalva maneuver, which is a bearing down, straining action. The vagal stimulation of the parasympathetic nervous system can cause a decrease in the rate at the sinoatrial node and can also decrease the excitability of the AV junction fibers. This causes a slowing of the heart rate and in severe cases, a complete blockage of the impulse through the AV junction. Okay. So I want you just to realize that bearing down or straining activity causes vagal stimulation of the parasympathetic nervous system and can decrease the heart rate, sometimes slowing it down so much that it results in a complete blockage of an impulse through that AV junction. And of course, nursing interventions do revolve around the fact that we have to maintain patency in all of our patients' IV lines, and that's so that we have rapid access to advanced cardiac life support protocol and the medications that are prescribed there. They have to be administered through intravenous means, especially some have to be IV push because we need it rapidly distributed and dispersed throughout the entire body. More nursing interventions are on this slide. Certainly we're going to provide psychosocial support for these patients with cardiac arrhythmias and also for their family members. This can be a very emotional time and even traumatic time for both patient and family members. So patients themselves may be fearful. This is where fear comes into play. They're afraid that they might die, and they might. So it's important to provide psychosocial support as well for both the patient and family. Promote adequate rest. We know that rest means that they will be less, there won't be as great a demand for oxygen for the heart muscle itself if the patient is resting. Certainly we have to maintain appropriate nutritional and fluid balances. And overall, when it comes to our cardiac patients, it's going to tend to lean toward fluid restrictions, okay? Because a lot of these patients also have heart failure, and more fluid increases preload and makes the heart have to work harder, and it requires more oxygen consumption and more of a demand for oxygen. So we want to make sure not to put the patient in the state of a fluid volume overload. Patient teaching includes all kinds of things. You have to be so educated as a cardiac nurse so that you can relay this information to our patients. They need to be told to report chest pain and dyspnea as well. And wellness teaching involves cessation of smoking. Smoking is very harmful in terms of causing coronary artery constrictions and causing irritability, ischemia for the heart, and irritability that can lead to these arrhythmias. Stress reduction is big. Weight reduction, heart-healthy diet. These are things we've mentioned before, so I'm just reading through it. all about their medications, which ones they need to take and why they're taking them, and relaxation is also with their stress reduction. Other patient teaching includes how they measure their blood pressures at home. There's a lot to know to get an accurate blood pressure reading, and how to also take their pulse daily and weigh themselves every day, and the reason behind weighing themselves every day. Oh, yes. Okay. I was going to say, I thought we already talked about that. We only talked about one nursing diagnosis, and that was decreased cardiac output. But this slide is talking about another nursing diagnosis that is very applicable to patients with dysrhythmias, and that is ineffective tissue perfusion. And I'll say it again, if you use this nursing diagnosis, ineffective tissue perfusion, you must put a comma and tell me what type you're talking about. Well, with our arrhythmia patients, we're talking about cardiopulmonary tissue perfusion. Okay. There's decreased tissue perfusion that is associated with dysrhythmias, and it's likely due to the decreased cardiac output. I think we've talked about that quite enough, and you probably understand that by now. So we have in this picture, for example, it's very easy for us to recognize. Okay, we don't have to identify any waveforms. This is very characteristic of torsades de pointes. Okay, here's the isoelectric line running right through the middle, and we have both upward and downward deflections here. Okay, so that's just an example of an arrhythmia. And when the patient has this type of ventricular tachycardia, there is a real problem in the heart being able to perfuse itself. Okay, it's both cardio and pulmonary, so these two systems are intertwined. Well, this is kind of out of order, but at this point, let's just go for it. So more nursing interventions. We already said this. Actually, this might just be a lot of repetition here, but assess the patient for the causative factors. And we already talked about identify the dysrhythmia. That's why we need to be able to identify the patient's dysrhythmia, because that's going to help us determine how we're going to treat it. And we need to determine if that dysrhythmia is causing a problem in the patient's perfusion. Are they having a difficulty perfusing certain tissues as a result of this decrease in cardiac output? Oh, this is huge, and they have lots of nursing questions related to this. Okay, so if there is dysrhythmia and it's impacting cardiac output, we can see that vital organs, including the brain, do not get oxygenated well. And what are the symptoms of that? Well, changes in level of consciousness, but they never say it like that. They typically will say that the patient is getting restless, then it's agitation, and then confusion. So we have any sign of confusion in the stem of the question would indicate that the patient is not getting oxygenation to the cerebral tissue. Okay. Also, there can be orthostatic changes in blood pressure. That's when they stand up, they don't receive enough oxygen to the brain, then they could even fall. They could have syncope as a result of that, and or dizziness as well. Also, we always have to assess our patients for any signs of pulmonary emboli, and this is specifically is referring to the atrial fibrillation arrhythmia, that irregular rhythm, because they form clots, and those clots can become dislodged, travel as an embolus, and end up in the lungs, causing a pulmonary embolus. So also we need to be able to monitor labs, arterial blood gases. You've already learned how to interpret arterial blood gas results. And so that we can look at the patient's oxygenation and also their their status in terms of whether they're acidotic or alkalotic. Also, we want to assess electrolytes, especially potassium, when it comes to the cardiac functioning, because most definitely, whether it's hypo or hyperkalemia, this can lead to cardiac arrhythmias in general. Okay, the BUN and creatinine, we monitor that to see if the kidneys are being perfused. Are they being affected by this poor perfusion or this decreased cardiac output? And we'll look at cardiac profile, and by that we mean especially cardiac enzymes, and also our lipoproteins that we want to look at, our lipid profiles as well, to see what type of condition their coronary arteries are in. We must always document chest pain, but most importantly, we must report it. Okay, and note any precipitating factors. Was there something that caused this chest pain to come on in your patient? Okay, we need to be aware of what that is. Encourage a restful atmosphere. Teach the patient what they can do to decrease cardiac workload. Do you know that even proper positioning in bed can decrease cardiac workload? I'll mention two things here that's very important that I don't think I've ever addressed with this group of students. And that is, first of all, if you would raise your hands, if you'd be a patient laying in your bed and you raised your arms and have your hands underneath your head because you're relaxing like that, that means that the heart is having to work harder. Okay, so no, they should not have their hands and arms above their head. They should be down at their side. Now, if the patient would sit up on the edge of the bed and dangle their feet, this is going to alter preload. Yes, because now more of the circulating blood volume is going to be out there in the periphery, especially think of it as more blood and gravity is going to be down in your feet and less returning to the right side of the heart. So by doing that, dangling your feet and keeping them below the level of the heart will indeed decrease preload or return to the right side of the heart. So positioning is definitely a factor that you may see in certain test questions. We already talked about medications and all the cardiac medications that they need to be educated about. Teach them how to administer medications. One thing I didn't tell you about was, and I can mention it here, that most of our statins, because I don't have a question about it on the exam right now for your exam 1, but statins are taken at night before the patient goes to bed. And I'm not sure your textbook explains it, but some textbooks have explained it. So I do know that the reason why they get their statins at night is because really around the midnight hour, late at night, is when the body is making cholesterol. Where did we say the cholesterol was made again? In the liver. But that's when our little cholesterol machines just go to work and make cholesterol. So it is beneficial for our patients to take that medication at night. We'll discuss lifestyle changes. Again, stop smoking. A heart-healthy diet, weight loss, appropriate exercises, and stress reduction. So I included a couple slides about ectopy because there were some questions in class today about it. And I've titled this ectopic foci. Okay, so know that there is a small area of the heart that can become more excitable than normal, which causes abnormal heartbeats to occur, called ectopy. Okay, E-C-T-O-P-Y, ectopy. Ectopic foci are usually caused by an irritable area in the heart. This irritability can be caused by ischemia, stimulants such as nicotine and caffeine, Lack of sleep or anxiety can also lead to this irritability and cause an irritable area of the heart, in the heart. So we see a picture here with the green. Obviously, that's not the SA node, that's not the AV node, but it's some other foci, little small area of the heart that's irritable and may decide to initiate an impulse on its own. So obviously you can see from this picture that the conduction pathways are completely different than if it had originated in the SA node. Okay. And this slide as well, we see a representation of ectopic foci. Here, ectopic focus would be one versus foci, which is more than one. And we also see the term ectopic pacemaker. So we see all kinds of words related to the same phenomenon. And you'll see here that the area and the yellow star shows the ventricular ectopic focus. And when that occurs, when that area gets irritable and initiates an impulse, it produces an early beat. It's a premature ventricular contraction. So even the PVC is here and exists because of an ectopic focus. Okay. You can also have, in the next picture, shows an atrial ectopic focus by this other color star here, more like maybe a pink color, sort of. It also, if it's in the atrium like this, it can cause an early beat as well. This one is a premature atrial contraction, which is what we see occurring here. So I hope that this brings a little bit of clarity to the topic of premature beats and ectopic beats. Now this slide makes the distinction between two procedures that we have going on in the hospital, especially for our hemodynamically compromised patients as a result of a dysrhythmia. So let's first talk about cardioversion. Cardioversion, sometimes also referred to as synchronized cardioversion, and you see that this nurse here has her paddles, so to speak, and she has the machine set to the sync mode. Synchronized cardioversion is shock delivery that is timed with the QRS complex. Okay? This synchronization avoids shock delivery during the refractory portion of the cardiac cycle, when a shock could produce ventricular fibrillation. In other words, we want to avoid shocking this person during the refractory period of the cardiac cycle because it could put the patient into a VFib, okay, which is a lethal arrhythmia. The shock dose used for synchronized shock is lower than that's used for defibrillation. As you can see in this picture, it says 50 to 200 joules. Okay. The treatment is going to depend on the level of the hemodynamic compromise. But when you press the sync key on the defibrillator, it enters sync mode. And the synchronizing circuit within the defibrillator will detect the patient's R waves. When we press the shock button, the unit discharges with the next detected R wave. Thus, we are avoiding the vulnerable T wave segment of the cardiac cycle. Okay. So, for example, if a patient has atrial flutter, you don't have to memorize this, but I'm just telling you that you can have the treatment and the amount of joules is going to depend on the patient's dysrhythmia and level of hemodynamic compromise. Okay, for atrial fibrillation, they may select even 25 joules. Okay, This slide says 50 to 200, but they could select even 25. For atrial fibrillation, if they want to convert that one, they're going to use 100 joules. And then they could also use it for other dysrhythmias that we really haven't talked about, but there's one called supraventricular tachycardia, and they may select 50 joules for that. So they can select different amounts of energy to attempt to cardiovert these rhythms. But certain rhythms, like we've discussed, are very sensitive to cardioversion, and low energy levels are likely to bring about the conversion. Okay. Truly AFib and VFib would require higher energy levels. Okay. Now, let's look at something that is called non-synchronized discharge of this energy. Okay. It would be defibrillation. It is not put on the sync mode to deliver this charge. Okay. We like to use defibrillation for VFib and VTAC, okay, because it requires higher levels of joules or energy to convert these rhythms. All right, so we already said the treatment for VFib is defib, so this is right in line with what we were saying. But we're going to start with a higher amount of energy, and that would be like 200 joules, and it can even go up to 360 joules. It depends on what type of defibrillator you're using. We have biphasic defibrillators which do not go above 200 joules. They don't need to in order to convert these rhythms. Now let's also look at the patients that would be scheduled, well, I wouldn't say the word scheduled. Let's say which patient population would undergo a cardioversion as compared to a defibrillation. Let's compare these two. Look at this patient. His eyes are wide open. That's because this is an elective procedure. Yes, they schedule a synchronized cardioversion. It is scheduled. Okay, tomorrow at 3 o'clock, the doctor's going to come by and we're going to do a cardioversion. The patient is awake, but we do sedate them, just a little bit of sedation to take the edge off of them. As we said, we put it on the sync mode, so it's synchronized with the R wave or the QRS complex. The patient signs a consent form before the procedure. It's in the chart. Okay, we have plenty of time. It's an elective procedure. The elective, not in the terms the patient gets a choice, but elective in terms that we can schedule it with the physician when it fits in. Usually it's the next day, may even be later that day, but it can be scheduled. The patient should be connected, excuse me, to an EKG monitor during this procedure. Now look over here at defibrillation. This patient is unconscious. Okay, eyes are closed. There is no sync, it's not turned to the sync mode. You need to call a code. The sync mode is off. You need to call a code. This is an emergency. Okay. This is used to treat VFib and VTAC. Remember the problem with those two dysrhythmias. These are lethal dysrhythmias, and it's because the heart has such a decrease in cardiac output that we're not even able to perfuse the vital organs, especially the brain, and therefore the patient becomes unconscious. We begin with a higher joules, like 200, and of course they're going to be connected to an EKG monitor so that we can observe and monitor the EKG response to this shock. Okay, so I like that slide. It's very good at summarizing the big differences between the two, which can be sometimes confusing. Now I have some questions for you. Let's do a little bit of select all that apply. A nurse cares for a patient with congestive heart failure. I've highlighted it in red so you can pay attention to those important words in the question. Who has a regular cardiac rhythm of 128 beats per minute? For which physiological alterations would the nurse assess? Physiological changes as a result of this, I hope you selected a decrease in cardiac output, especially when you combine that with a heart failure patient. Okay, it's not only that it's going way too fast, but the patient has heart failure. So you're going to have a decrease in cardiac output. And that automatically means that you have a decrease in blood pressure. Okay, so that's a C, A and C. And hopefully you even thought that one step further. We know with a decrease in cardiac output and blood pressure that the kidneys may not be perfused well. So we're also going to assess for decreases in urine output, which is what we find when the kidneys are not being perfused. So you should have A, C, and E all selected if you understand those physiological changes of this patient. Another select all that apply. A nurse is teaching a patient about premature ectopic beats. Which education would the nurse include in this patient's teaching? Well, answers would be smoking cessation, absolutely, okay, and stress reduction and management, and adverse effects of medications. So there's 3 correct answers. The other 2 have nothing to do with premature beats, but smoking, stress, and perhaps adverse effects of medications would be important to teach the patient about. Here's an NCLEX style question. A nurse administers prescribed adenosine, which is Adenocard. This comes from our last lecture, earlier, part 1 of this lecture. Which response would the nurse assess for as the expected therapeutic response? Okay, remember adenosine is used for chemical cardioversions, and we have to IV push it very fast. And what are we expecting to see? Yes, ideally, we would like to see a short period of asystole and then for the heart to automatically start beating again and hopefully a normal sinus rhythm. So C is the correct answer. A nurse assesses a patient with atrial fibrillation. Which manifestation would alert the nurse to the possibility of a serious complication from this condition? I put this in here purposefully because I need you to understand and start connecting the pieces to work on our critical thinking. So we know with AFib that they run the risk of forming clots and those dislodging and becoming an embolus. They can go to the brain and result in a stroke. You have to make those connecting pieces because of your understanding of this pathophysiology. So of course, the serious complication would be a stroke. Which of these indicates stroke? B, a change in speech. Okay, B. A nurse is assessing patients on a med-surg unit. Which patient would the nurse identify as being at greatest risk for atrial fibrillation? And I hope you picked B, a 50-year-old who is post-coronary artery bypass graft surgery. Okay, so this patient has a double whammy because he already has coronary artery disease and apparently multiple vessels. So he has a lot of coronary disease, And also he's just had a major open heart surgery, and that is very common for these patients after surgery to develop a fib.